Dr. Stephanie Graff, MD, FACP, is Director of both Clinical Research and the Breast Program at Sara Cancer Institute at HCA Midwest, as well as Associate Director of the Breast Cancer Research Program at Sara Research Institute and National Breast Lead for the Sara Cancer Network's clinical programs. She is board certified in medical oncology, hematology, and internal medicine, and completed a breast oncology sub-fellowship at the University of Kansas. In addition, she leads the high-risk women's program both at Sara HCA Midwest Health and for the Sara Breast Cancer Network. In 2020, Dr. Graff joined the Dr. Susan Love Foundation for Breast Cancer Research as medical advisor. Dr. Graff has broad experience as a principal investigator on numerous clinical trials and multiple publications. She is an award-winning writer, social media influencer, and sought-after public speaker. Dr. Graff has received the first humanitarian award for her work in the community volunteers on the American Cancer Society Kansas/Kansas City Area Board and the Research Foundation Board. She is active in the American Society of Clinical Oncology, serving on several committees, and is a recent graduate of the ASCO Leadership Development Program. Ultimately, Dr. Graff is passionate about connecting with her patients to provide personalized, comprehensive oncology care, advancing breast cancer research and breast cancer prevention.
We met in 2019 after I was diagnosed having invasive ductal carcinoma breast cancer. And although there were pre-treatment educational meetings, I still had no idea what to expect. But the professional mannerisms and beautiful smile helped to calm my thoughts, my nerves of the unknown, what I was about to hear and expect. My husband, Ron, and I so appreciate that of you. And I am speaking of none other than Dr. Stephanie Graff. I'm just truly excited about what everyone is going to learn and hear about today, because I know that you have truly been a blessing to me as well as to my husband, and we thank you so much for that. So how have you been?
I'm good. I'm really excited to be here with you too.
Yeah, and how's everything going with doing all this pandemic stuff?
You know, actually really good. In some ways, the pandemic has been strangely nice for my patients with cancer because with everybody sheltering and working from home and wearing masks and washing their hands for patients on chemotherapy, the world's a little safer and they're not missing out on stuff because there's nothing to miss out on. So in some ways it's made the experience of being a person on chemotherapy a little bit easier.
Yeah, I bet. And that's good. And it's so important. I know each time that I have to come into the center, they make sure that they take my temperature and, you know, we got the little label for the day that we were in. And so it's good. Yeah. We do have to be safe. We can't be too careful. All right. I have a question for you. Well, I have several questions, but I'm going to start off with being the director over oncology at Sara Research Center. As an oncologist, you specialize in diagnosing and treatment of tumors, better known as cancer. And I know for sure that you specialize and treat breast cancer. Are there any other types of cancers that you specialize and treat as well? And are you a surgeon as well?
Great question. So I am a breast medical oncologist. I'm board certified in medical oncology and hematology. So I can technically treat any cancer or blood disease, but my area of expertise is breast cancer. So I'm actually lucky to practice in a practice environment where I don't have to treat any type of cancer except for breast cancer, which allows me to have that extra laser focus. I think a lot of physicians do an amazing job taking care of the full spectrum of cancers. course.
Yeah.
And then there's a handful of us across the country that just focus on one disease type. I am not a surgeon. One of the things that I really love about cancer care is that we get to practice in these multidisciplinary teams. So I do medicines and chemotherapies and targeted therapies. And I tend to consider myself sort of the quarterback of the team. I'm also in charge of most patients' long-term follow-up and making sure that their imaging is happening and that sort of stuff. But we also have breast surgeons, and we also have radiation oncologists and radiologists, the people reading your breast imaging, and pathologists who are looking at your tissue under the microscope. And all of those people work together. We have team meetings, and I talk to all of those people about as often as I talk to my husband. And it's really fun to work together.
Oh, I bet. And there's a lot. I mean, I'm familiar with a few of those departments, the pathology and radiology.
All of those departments.
Yeah, really, really. How did you get into this awesome field?
Oh, gosh. So one of my mentors in high school, so a long time ago, used to tell me that whatever you decide to do in life, you have to love to read about, because your job will be to read about your job. And there has never been truer advice given, because my job is to read about my job. And when I got, in school, I loved math and science. It was the stuff, I'm a total nerd. It was the stuff I couldn't put down. And when I got into medical school, the math and science, or the science of oncology in particular, the pharmacology of the drugs, the pathophysiology of cancer was really interesting to me. And then as I transitioned into clinical rotations, cancer, I mean, in a way that's so unique, we get to know our patients so deeply. I mean, it's such a terrifying time for many patients, and we see each other so frequently as somebody goes through treatment. I really often get to know my patient as well as their family, their husbands, their children.
Yeah, because you even had the opportunity to meet my
really
family.
Resonates with me. Yeah.
Yeah. But I know that I'm grateful for you, and I'm sure that the other patients are as well. I know last October, you and I had the privilege of being interviewed live with KCTV5 for Breast Cancer Awareness Month. And I know that people always think that there's probably just maybe one type of breast cancer. Now, help me out, because I'm a little bit familiar with 4 types, I believe. And I think those types are, it's a cyst tube, and invasive ductal carcinoma, and inflammatory and metastatic breast cancer. I'm sure there may be others, but are these the most common 4 breast cancers that you find? And will you explain the difference between them? Was that a mouthful?
Great question. So yeah, it's a mouthful. I wish I had like a dry erase board that I could take notes in. I'm teaching class now. Students gather around. So when I think about what an individual's breast cancer is, there's a bunch of different things. The first is what pathology that person has. And the most common type of pathology is ductal carcinoma. But there is also lobular carcinoma, which is the second most common type. And then there's a bunch of rarer ones that we don't hear about as much. Metaplastic, tubular, I could go on, it doesn't matter. There's a bunch of rare ones. And then, so that's the pathology type. We also look at the grade. Is it grade 1, grade 2, grade 3, which some people call low grade, intermediate grade, or high grade.
Right.
There's the staging, and the staging tells us how big the cancer is, if the lymph nodes are involved, and if there's any evidence that it's spread anywhere outside of the breast. Now, that's the difference between in situ or metastatic. So metastatic means it spreads somewhere else in your body. In situ means it hasn't even left the ductal structure or the lobular structure that it started in. So an in situ cancer is actually considered a stage 0 breast cancer. A metastatic breast cancer, this is something that a lot of patients maybe don't understand, or lay public doesn't understand, is that when a cancer spreads outside of the organ that it started in. So if a breast cancer spreads to the lung, if a lung cancer spreads to the liver, it still looks like that cancer. So to me as a scientist, that's really cool. To you as the person living with that, that is very not cool. But it would literally look like there was a breast trying to grow in the middle of your lung, or a lung trying to grow in the middle of your liver.
Wow.
So we can tell where that cancer started. Based on how it looks under the microscope. And then the last thing that we look at is in breast cancer, at least, is something called the prognostic profile, or the markers. And those are things like estrogen receptor, progesterone receptor, and HER2. And that helps us understand what's making the cancer grow. And you can be positive for some of those, both of those, or negative for all of those. And when you're negative for all three of those, it's called triple negative. And so now I just rattled off pathology, grade, stage, and markers. And those four things each have, you know, three different categories, and those three different categories can combine in any possible combination. So although we think of breast cancer as one disease, it's really dozens, hundreds of diseases based on how all of those different things factor together.
Wow, wow. Now I know breast cancer is not
complicated.
Yeah, and cancer, we know that cancer, and especially breast cancer, is not gender specific. So can these cancers also be found in males? I mean, and, you know, I'm thinking, what causes this? Is it hormonal? Can it be from medication? Can it be from obesity? Can it be from genetics, you know? So can we find these same cancers in men, and then the causes of them?
Yeah, men absolutely can get breast cancer. Obviously, it's less common. So about 1 in 8 women will get breast cancer in her lifetime. And I think the statistic, I would need to double check it, is that 1 in like 300 men get breast cancer in their lifetime. So it's not impossible. I have, unfortunately, lots of men with breast cancer. And the risk factors are actually relatively similar. So for a woman, the #1 risk factor for getting breast cancer is getting older. And a lot of patients don't realize that. People look at me every day and tell me that they don't have any risk factors. And I'm like, well, you keep having birthdays, so you have a risk
I guess
factor.
that's what happened to me.
So for men, most men that get breast cancer in their 70s. And their risk factor is aging. Alcohol and tobacco are risk factors for breast cancer in men and women alike. Genetic factors are a clear risk factor for breast cancer in men and women. Men who have a BRCA2 mutation, for example, are probably at the highest risk. There's a disease called Klinefelter syndrome, which is a genetic alteration that men can have that affects their sexual development and hormone development, that significantly increases their risk of breast cancer as well. Currently, the #1 risk factor for breast cancer in the United States is obesity, and that affects men the same as it does women. A lot of people think it's family history, and it's not. It's obesity right now, which is terrifying. So I find that a lot of the risk factors are shared risk factors independent of gender.
Wow. I was shocked and a little bit to hear that it is obesity. You know, I was thinking that it was probably going to be more genetics. And I think that's what a lot of people do think. So it's interesting to hear that the diet, or an unhealthy diet, I guess, can cause cancer, those eating cancer cells to come alive. What are some preventive measures? I mean, what can people do to prevent? I mean, we know if it's obesity, to scale back from the table and to eat more healthier. But what are some others would you consider?
I try to use the phrase risk reduction as much as I can, because nothing's completely preventative, right? You can do everything right or everything wrong, and you can still get or not get good and bad things in your life. Optimal strategies for risk reduction of breast cancer would include avoiding hormone replacement therapy after menopause. With the publication of the Women's Health Initiative showing that hormone replacement therapy increased the risk of breast cancer, and subsequently a lot of women choosing not to be on hormone replacement therapy, we saw the risk of breast cancer decrease significantly.
Mm-hmm.
Hormone replacement therapy is not purely bad. A lot of women, when they hit menopause, are miserable. They'll have terrible side effects.
I had terrible side effects.
And there's good evidence that hormone replacement therapy for a short period of time, 2 to 3 years, maybe as long as 5 years, where a woman sort of gradually tapers those hormones so that they can feel like they rolled down the hill instead of got pushed off the cliff, is safe from a breast cancer risk perspective. But that's what I recommend, a short period with a taper. Maintaining an ideal body weight. It is clear that obesity, particularly after menopause, is a significant risk factor for breast cancer. And we know that losing weight after menopause is really, really hard. So the time to start thinking about being your ideal body weight is today. 20, 30, 40-year-old women listening to this, it's today that you need to be thinking about losing weight, because it's not going to get easier as you get older. Again, if you go online and Google ideal body weight, everybody's ideal body weight is ridiculous. I think my ideal body weight is like 120 pounds. I can't imagine I'd have like a 6-pack. It'd be the closer to your ideal body weight you can be, the better. I also really encourage patients to focus on things like increasing water, increasing vegetables, increasing strength training, having more muscle mass drives metabolism. And so often women just are focusing on the wrong things when they're trying to lose weight, and it's not a healthy cycle.
Yeah.
Alcohol is a risk factor for breast cancer. And the statistic for women is that women should be drinking less than 7 alcoholic beverages a week. The catch with that is that an alcoholic beverage in that context is like the medical definition of an alcoholic beverage, where it's a shot of hard alcohol or a 4-ounce glass of wine or like a 6-ounce beer. And those are not the serving sizes. Like I joke about the Johnson County mom wine glass, which is like when my friends have a glass of wine, it's like a half a bottle, which is what I joke. I'm like, if you do that twice a week, you're over 7 glasses. I mean, you've exceeded your weekly alcohol intake to increase your risk of breast cancer. So again, everything in moderation, but particularly mindful about decreasing alcohol intake, I think for a lot of women is key. Interestingly, there's lots of data from the pandemic that women have significantly increased their alcohol intake during the pandemic, which I find startling and dangerous. Gosh, those are the big sort of lifestyle factors. Exercise helps reduce the risk even if you don't lose weight. So exercise independent of weight loss helps lower risk. And then I really think for persons with a striking family history of breast cancer, ovarian cancer, prostate cancer in young men, pancreatic cancer in anyone, need to be aware of those and potentially talk to a genetic counselor about whether or not they qualify for genetic testing.
When you say young man, how young? What age?
So prostate cancer is a disease that sort of, again, is a normal mark of aging. Prostate cancer is in men, it's pretty common around 70 or so. I would say if there were men in your family with prostate cancer in their 60s, definitely in their 50s, that's young and unusual, and is a marker that they are at an increased risk to have a genetically mediated prostate cancer. So the BRCA1 and BRCA2 genes, the genes that are most often associated with breast cancer, increase the risk of prostate cancer in men. So men with very young prostate cancers, it's a warning sign of a BRCA1 or BRCA2 mutation.
Wow. When you were talking about hormonal treatments with women, now most people don't believe this, but I do, and I did some research on it, even when I was in my therapy class, and I did a paper on it, that men have a type of menopause. And so that their hormone level can go down. It can cause depression. It can cause other things. And there's a hormonal treatment for males to take as well. Would that increase their chance of getting cancer? for breast cancer?
It's not abundantly clear. It's not abundantly clear and it's complicated. So I jokingly call that menopause, when men hit menopause. There are men that men can hit a menopause-like syndrome in their 70s. And often testosterone replacement will help those symptoms. It's unclear if testosterone replacement at that age significantly increases the risk of breast cancer, in part because most men probably don't take it long enough or in a manner that's fully disclosed in medicine, because sometimes they're taking that from like health clinics that it's not always tracked. We don't know.
You don't know. Okay.
Yeah.
Well, I know when I was reading the American Cancer Society stats, it read that second to the Hispanic community, that the Black female community has the second highest risk and fatal percentage of breast cancer, opposed to other ethnicities like whites or Asians. So one other good thing that I read, well, that wasn't a good thing, but one thing that I did read was that for the Black men, breast cancer was down by 2%. So there's that percentage rate. But from your professional experience, Dr. Graff, how true do you think this is, and why do you think it is so for the Black community, the female Black community, to be at higher risk and have a higher fatality of breast cancer than others outside of Hispanics?
So again, kind of an unanswered question in medicine, but it is abundantly clear. The data tells us that the breast cancer specific mortality, so the chances of dying from breast cancer, is 41% higher. 41%. It's a statistic that's so terrifying, I can't forget it.
Oh my goodness.
For Black women than white women,
Oh
despite the fact that Black women are less likely to get breast cancer than white women. And that is corrected for stage of diagnosis. So even when you're correcting for that Black women are more likely to get later stage breast cancers because there's delays in diagnosis, delays in screening, barriers, access to screening issues, they're 41% more likely to die. And you know, I can run a list of 100,000 reasons why that could be. And the truth is that we don't have comprehensive answers. I think part of it is racism, point blank. I think there's a lot of structural barriers in the way that the Black community is able to access healthcare. I think there are a lot of social inequities in the healthcare system that make it difficult to be a consumer of healthcare. Communication barriers between physicians and patients that are difficult to overcome. You know, there's been pioneering work by Harold Freeman, who's a Black healthcare leader, physician, developing patient navigation in Harlem specifically to try to overcome that. And so a lot of navigation programs are really looking at social determinants of health, poverty, structural barriers to try to improve access and timely care to try to help close that gap. But even with patient navigation, we still see significant disparities by race and outcomes for cancer. Black women are more likely to have biologically aggressive breast cancers. There's not clear reasons why that is. It's hard to know if there are, I mean, my guess is that it may be more environmental. I don't know exactly what I mean by that. I don't believe that it's genetic. I mean, we're 99.99999 the same, okay, regardless of what color our skin is. I don't think that there's anything fundamentally different, but environmentally, we live in different parts of town. We have access to different foods. We are exposed to different things in workplaces. We have different stressors in our life. And all of those things affect our biology. They affect everything. And we see that in, you know, there's really elegant studies looking at the effect of just a single generation of immigrants to the US on things like high blood pressure, that persons that are Black living in Africa don't have it, and then they move here and they do. And that's not genetic.
No.
So,
you know, I find it interesting that a couple of my girlfriends, I've lost two really close girlfriends to breast cancer. And their story was a little different because they decided to go a health route, you know, a holistic health route, and not have the treatment. Yet I've had some friends to go, and they felt or found a lump in their breast, went to the doctor and was told, oh, it's nothing, don't worry about it. I asked, was the mammogram done? You know, any other type of testing done? Yes, they said it's just a little tissue, it's a little mass, don't worry about it. If it's not hurting, come back in 6 months and we'll see if anything. And I'm concerned about that because when I asked one of my white girlfriends, when she had it, it was taken care of right away. And I was just like, okay, what's that about? I mean, is that a normal procedure? No, that's what we're speaking
yeah, and
about.
I think, I mean, again, that's that communication barrier and confirmation, but things I wish I could fix in the world, right? That's a little bit of, so, you know, I don't know how much of that is a communication barrier between that patient and that physician on whether or not the level of concern, the manner, that interaction really said, I'm really concerned about this. Okay, let's check it out. If that went the way between those two people speaking the same language. I know that part of our job as physicians is to have a differential, which is like the list of things we think is wrong with somebody. And because breast cancer is so much more prevalent in white women, I imagine that when a white woman says to a physician, I've got a lump in my breast cancer is there in the list. And maybe for some physicians, the differential is different for someone else, and it shouldn't be, because the list of things that could cause a lump in your breast is a pretty short list.
Yeah.
It's either cancer or it's a not cancer lump, but the workup's the same. You need to go get breast imaging.
Yeah.
And so it's frustrating that I have countless patients with that story, and I can't fix it.
Yeah. I know that in September 2010, I believe it was, when President Obama signed for women 40 and older to have annual mammograms. That was like free of no charge. Some people still didn't get it. Some women still weren't able to get it because their jobs were still up under the old father, feathered plan. So when the annual mammogram was passed back in 2010, have you noticed any significant changes being made to improve breast treatment for African-American women and other people of color? I know we kind of touched on it, but I want to know, just within these last, almost 10, going on 11 years, have you noticed any improvement?
I don't necessarily know that Obama's order per se caused a big shift, at least in my awareness. And it may have affected different communities differently. I can say that I feel like there's been some better momentum in the post-George Floyd era, which has been pleasant to see, needed to see.
Yes.
Unfortunate that it took
so long, for sure.
Get.
Yeah.
And so examples more specific, like to be specific of those examples. One of our big national breast cancer conferences where all the doctors get together and figure out what's the latest and greatest new thing in breast cancer is called the San Antonio Breast Cancer Symposium. And it's sponsored by the American Academy of Cancer Research, or AACR.
Okay.
And this year at the AACR, the keynote presentation, so like the one part of the conference that everybody's in the same room for and actually sits and listens to, was on disparities in care.
Mm-hmm.
And for the first time ever, it wasn't led by a physician or a scientist, it was led by a patient advocate.
Wow.
So they actually had a patient lead it. And the patient that they had lead it was a Black woman. His name is Mima. What?
I said that had to be an ear opener.
Yeah, she's amazing. And she runs a nonprofit called the Tiger Lily Foundation. And during that session, they presented numerous different abstract scientific studies looking at disparities in everything from communications to structural barriers in care, to outcomes, to even genomic alterations and differences across ethnic groups. That was very interesting. And so to see a international cancer conference sponsored by a world-leading cancer organization highlight the voice of a Black female patient advocate and center stage disparities was huge.
Yeah. And will you say
ASCO, the American Society, her name's Mima, M-A-I-M-A-H. And I'm sorry, I so think of her as her first name like Oprah that I can't even think of her last name.
And she's with the Tiger Lily.
And her foundation is called the Tiger Lily Foundation.
Thank you. Yeah.
She really just needs a first name like Cher or Beyonce. Or
yeah, but I can look her up, but that's good for us to know.
Yeah, she's amazing. So that's one example. ASCO, the American Society of Clinical Oncology, is following suit and is going to have a similar session at their big cancer conference, which is in June. ASCO, for the first time, has a Black female president.
Wow.
And her presidential theme is on healthcare disparities. And one of her big presidential pushes is to try to increase diversity among oncologists. Because honestly, that's another issue. I mean, there's also clear evidence that, again, less good evidence in oncology, better evidence in other fields, but like in OBGYN, for example, there's evidence that Black women have better outcomes if their OBGYN is a Black woman. And that maternal fetal outcomes are better when Black women get care from Black OBGYNs. And I anticipate that the same will be true in cancer care.
Yeah.
And there's just not enough diversity in the oncology community providing care to the Black community. And but there is nice evidence in cardiology that even a single, if you've got a group of 10 cardiologists and one is ethnically diverse, that the whole team of 10 cardiology has an elevation in their care of ethnically diverse patient populations. So I think that we don't necessarily need all of the oncologists to be ethnically diverse, but increasing the ethnic diversity of the physician population is going to help promote that thinking more across the board.
Yeah, yeah. And most people are comfortable with someone that looks like them. And when it comes to the African-American Black community, a lot of times there's that uncomfortableness or that fear, or, I'm not going to go, they're not going to tell me the truth. What do they know about me as a Black person? And so it does make a difference. I know in my profession as a psychotherapist, it makes a difference to a lot of the clients that I have had, whether I'm female, Black female, or something like that. And so we do want everybody to feel comfortable, but that's so good for both associations now to be having these people of color to present, which helps everyone to hear, and I think to hear mindfully, to hear differently, and to have a lot of awareness that wasn't there.
Yeah.
So what I would like to ask you, because this was a biggie for me, what should a patient expect when they first come to see you as an oncologist? So is it going to be a physical exam, immediate surgery or treatment, or is it going to be a video with popcorn and soda?
No, there should not be a video. No, I think that your first appointment with every doctor you meet should be getting to know you and information gathering.
Yeah.
There should be no immediate action. Nobody should cut you or treat you the first time you meet them. That's scary and weird. You should run away from that. And I think that, globally, what I would tell people is that you should leave your first appointment feeling better, not worse.
Yeah.
You should trust your gut. Your physician, you should feel connected to your physician, because if you don't, you're already behind the mark on that, being able to communicate effectively, which is the most important thing. I think that there's going to be times where at your first appointment, your doctor doesn't know everything yet. I mean, sometimes you're going to need additional imaging or biopsies, or we won't have all of those markers back. And your doctor is going to look at you and say, there's still holes in the story that we need to fill out so that I can tell you what the comprehensive plan is going to look like.
Yeah.
But they should be able to talk you through what those steps are going to be and give you a plan on when they're going to meet you next to talk through everything.
So
and offer you support and reassurance.
Yeah. And so I remember my mapping. And I can't remember if that was the first visit or the second visit, but I want to share this.
Oh no, you're going to pull it out of somewhere.
Pull it up. I love it. I'm going to keep it forever. So this is what,
there it is.
This is what you gave me. And was this at our first visit with my husband and I?
That was probably at your first visit. It's at most patients' first visit.
Yeah. And so you stated from your bio that all treatments are and mappings are personalized. So what I'm hearing there is not a one treatment fits all per patient.
Yeah.
Yeah, so this is kind of interesting. I didn't know if you wanted to talk to it or not, but I just wanted the viewers to see what they possibly could expect to get on the first visit.
Yeah. Yeah. There's, I don't know, thousands of those running all around Kansas City, I suspect, at this point, and the Midwest, and in my handwriting, my blue pen, they all look just like that. But that top part of all of that stuff, tumor types, grade, stage, prognostic markers, is a little bit different on everyone, which makes the bottom part completely different.
Yes.
Not every doctor is going to write all that out for you.
Mm-hmm.
You should, I wish every doctor would write everything out for you. I wish every doctor would sit down and talk to everybody about every little detail. Oncologists on the whole are fantastic communicators and really want you to know and understand your disease, because cancer is big and scary, really, and we understand that.
Yeah.
And I want you to, what I want is for you as a patient to understand your disease well enough that when you go home and Google at 2 o'clock in the morning, because let's face it, you're going to go home and Google at 2 o'clock in the morning, that you don't Google the wrong thing and end up terrified, right? Like if you don't know the stage or the markers or the difference between invasive and inflammatory, or stage 1 and stage 4, or triple negative and ER positive, I mean, you can just really end up in a weird rabbit hole.
For sure. And so how do you respond to patients, if you've had any, that come in with this folder full of research that they've gotten off of Google, and here's my diagnosis, and these are the treatments that I feel I should have, and so how do you respond to that?
With patience and grace, hopefully 97% of the time. Every once in a while I'll be like, oh Lord. Typically when somebody brings me a whole bunch of research, I first ask if I can tell them everything I want them to know first and do what you just showed, so that I make sure that we're on the same place, that I want them to know what I know about their cancer. Then I ask if we can go through their folder together and talk about what's in their folder that's relevant or irrelevant to them, because sometimes stuff that they've searched is not the right search. Yeah. And it's very quickly to say, okay, this isn't on your map because of that. And sometimes that very quickly weeds down that folder. And sometimes the stuff in their folder is exactly the things we just talked about. I can say, look, this supports everything we just talked about. If you want to read this in detail, this is the data that supports B2 that we talked about right here. And sometimes I'll say, you know, if you want me to, I have one patient actually comes to mind. I have one patient who just wants to read the actual scientific medical literature that supports every decision that I'm making for her. She doesn't understand it. She's not, I mean, she like point blank will be like, I have no idea what I'm reading, but I want to read it so that I can say that I read it. And I'm like, okay, I'll keep printing them out and handing them to you. You know, we all, at the end of the day, we're all going to cope with stressful life events in our own way. Yeah. And for some of us, we're going to take a hot bath and turn off the lights and pretend we're not home. And some of us are going to drown ourselves in 2 a.m. Google searches. Yeah. And some of us are going to cry on the floor of our closets. And some of us are going to turn to prayer. And some of us are going to turn to our trusted friends and colleagues, and it's just going to look different for everybody, and that's okay. I can respect that. I hope that whoever is listening, I hope your oncologist can respect that. Yeah. But get the support that you need to.
So I just have a few more questions real quick. So can a patient decline treatment? Let's say they have concerns about their fertility being affected by chemo or radiation. So can they decline treatments, and how do you respond to that? And also I know that there have been, like one of my friends did not have treatment because she was afraid she was going to have a mastectomy. And so is that a common treatment? I mean, does that always have to be? And so I also want to know what are some of the time frames and side effects of the treatments. Now full again.
Okay, two-part question. First, infertility. So there are lots of things that we can do to help protect persons from infertility for cancer treatment. First off, there is almost always time to go through infertility treatment. So for patients that need chemotherapy, which is really the at-risk procedure part of the treatment, we can send them to reproductive endocrinology, and they can have an egg harvest and have embryos or eggs frozen and preserved that they can then use after their cancer treatment safely. There are some nonprofits that can help offset that cost that we can apply for. And so there's lots of opportunities. Secondly, there are treatments that we can give with chemotherapy to decrease the chances that someone would become infertile with their chemo. And I do that all the time. I actually normally do that even when people tell me that they don't care if they become infertile. I say, I know you're saying that now, but you're 32 and we're just going to be better safe than sorry, so that when you're 36, you don't regret that. And we did, because why? It doesn't change anything about your outcome or your breast cancer treatment or anything. It's just, you just get an extra medicine. Just
change their minds, they'll be safe.
Yeah, it's perfect. Right. So there's lots that can be done, and they just need to bring that up early and openly so that their doctor can factor it into their treatment plan. Yeah. Radiation will not affect somebody's fertility, because when we're doing breast radiation, the only part of their body that's getting radiated is their breast, and their breast does not make babies. Nothing is going to change about your baby-making skills if your breast gets radiated. If your radiation oncologist accidentally hits your ovaries while they're radiating your breast, they have missed. And then we have very different problems that we need to discuss.
For sure.
So that's not a concern. Same thing with surgery, not a concern. Second part of your question was about lumpectomy versus mastectomy. So there are some rare situations where the only option is a mastectomy, most notably inflammatory breast cancer, which is pretty rare. Mm-hmm. For the vast majority of patients, either choice, lumpectomy, where we just remove the tumor, which is also sometimes called breast conserving surgery, mm-hmm. or mastectomy, where we remove the whole breast, are 100% reasonable choices. For patients who are, for some other reason, not a candidate for mastectomy, or sorry, not a candidate for lumpectomy, the breast conserving surgery, but who really, really want that, sometimes we can do some treatment before surgery to try to shrink their cancer to make them candidates for that surgery.
I see.
And sometimes if that is the centrally important part of somebody's care, if somebody says, listen, it's a lumpectomy or I'm not going to do anything, mm-hmm. you'd be amazed how many mountains can be moved to make a lumpectomy possible. Breast reconstruction. So for patients that have a mastectomy, have their breast removed, breast reconstruction is covered by insurance. And a plastic surgeon can recreate new breast form. Mm. I do not mean to say that a reconstructed breast is exactly what you started with, mm-hmm. but it recreates breast form. Even for patients choosing lumpectomy, there's an opportunity to incorporate a breast reconstruction plan. So I've had patients that do a lumpectomy and do a reduction on the other side because they've always felt too big and they want both sides smaller. And I've had patients that because they have a bigger tumor and want a lumpectomy, they have a reduction on the other side to give them better symmetry afterwards. Mm-hmm. I've also had patients that have a lumpectomy, but have always felt like their breasts are too small. And so at the time of their lumpectomy, they have bilateral augmentations and make both sides bigger. And it's covered by insurance, which is crazy.
Yeah.
So there's lots of options, mm-hmm. and we just figure it out.
Yeah. I know our time is almost up, and this has just been so great and is so great. I'm enjoying it for a second time around. Side effects. What are maybe 2 common side effects? I know that I still have side effects from lymphedema. What would you say to that? And I'll come back to the last question.
Side effects are as individualized as the treatment plan. So I don't know that I can answer that as too common because there's like 1,000 and it depends on what treatment you get. I guess what I would tell, so here's my answer, and it's a total cop-out because I'm not really answering. Side effects are things that can happen, not things that will happen. Mm. So I think that sometimes when we hear about the side effects of chemotherapy or cancer treatment, or if we Google a medicine or pull up the pharmacy package insert when we pick up our medicine at the pharmacy, it is terrifying. They're like 70 pages long and have 100 things. I mean, like you could get attacked by a bus full of clowns. It is terrifying. But that doesn't mean that's going to happen. Just because something can doesn't mean it will. The incidence, the likelihood that some of these side effects happen, a lot of them are less than 10%. 90% of patients take these medicines and are just fine. So what I tell patients most of the time is just try it. And if you feel bad, then we'll figure it out. Maybe we quit, I don't know. But to not even try because you're afraid that something might happen, I don't know that that's really who we are.
Yeah. Has the survival rate increased for stage 3 and 4 breast cancer over the last 10 years?
Yeah. And for all types of breast cancer, 0, 1, 2, 3, 4, it's slow and steady progress. It's not what I would want it to be. I mean, I want to be able to say that there's a cure. I want to be able to say that people will live forever, and I can't still. I think that both our supportive care medicines, our medicines to control things like low blood counts or nausea or whatever, are getting better. And the better we get at supporting people through treatment, the more likely people are able to finish their whole treatment, to not have complications of their treatment. All of that improves outcome. The more and more we're able to improve access to care, the longer people are able to stay on treatment and continue to see their physicians and get good follow-up. That improves survival. We also, in the HER2 positive breast cancer and an estrogen receptor positive breast cancer in particular, have had big advances in terms of new medicines being approved. In triple negative breast cancer, we have 2 targeted therapies approved for the first time, both immunotherapy and then a targeted therapy called sacituzumab govitecan. There's a spelling test at the end, everybody. And so all of those are really great advances that we're getting new medicines available to us.
And do you see this across the board for each culture, each ethnicity, or, I mean, how is it looking across the board for every culture and race?
Those are all global advances. I think, again, when you look at participation in clinical trials, which are where these advances are made, there's a disparity in clinical trial research. I know that, so immunotherapy has been, the sort of pioneers of immunotherapy was lung cancer research, and early data showed us that the number of Black persons treated on the immunotherapy trials was shockingly low in lung cancer, despite the fact that lung cancer is very prevalent in the Black community. And there was a big outcry, particularly from regulators. The FDA would kind of call industry out on a push to really focus on recruiting more diverse patients to clinical trials. But of course, there's a longstanding trust issue participating in clinical research with the Black community.
But my husband, I'm sorry.
So I think that that's another potential cause of some of the disparities that we see. If there are biologic or environmental differences in how Black versus white versus Latino versus whatever respond to these medicines, the only way to know that is to have them participating in equal numbers or representative numbers in clinical research.
Sure. My husband, Ron, and I, we started the Garnett Cancer Society nonprofit back in 2019 after my diagnosis and treatments. And one of the main reasons that we started that too was because of the information that I received prior to treatment, that not all ethnicities respond the same to treatments. And so that there was a much less study on Black-brown population due to the lack of surgically removed cancer tissues being donated for research study. And you were part of the medical advisor for the Dr. Susan Love Foundation breast cancer research. I know we talked a little bit about genetics and all of that, but what is happening when a surgically removed tumor is donated or tissues is donated to research? What do you see and how do you use that? And is genetics included with that? Does that make sense?
Right. So, it depends on what it's donated to or why or when. So to be clear, your tissue is never donated. Your tissue is your tissue, even when it's still on a shelf down in pathology. Okay, like that's still you and it's still your rights as a patient, and it's not donated without your awareness. So you will sign a consent form that says what your tissue is being donated to and why, and what testing is going to be done on it, yes. And whether or not you will be informed of the results of that testing.
Right.
So, I mean, I think that those are all the things that you would always want to know, is if genetics is a part of that, and if that result is disclosed to you. Genetics are different than genomics. So genetics is genes that you could have inherited from your parents and passed to your children. Genomics are the unique genes of your cancer, which really could be, that isn't really you anymore, right? Like, it's mutated former parts of you, and it doesn't have anything to do with heritability passed from parent to child. But for the most part, that's all spelled out very clearly in a consent form. And is something that you would be asking about when you sign. Yeah. You mentioned the Love Research Foundation. That's a great opportunity for patients that are interested in signing up for research. The Dr. Susan Love Research Foundation does have an arm of our organization called the Love Research Army. And the way that the Army works is that patients sign up, or persons sign up. You don't have to be a cancer survivor. You don't have to be a man or a woman or a certain age or anything like that. You just have to have a heart that says, I'm interested in learning more about breast cancer research. And it's basically a giant email chain. And every time there's a new study that's looking for volunteers, the whole email list gets emailed about that study. We don't try to tailor the email list to, like, if it's like, right now we have a study for male breast cancer. Mm-hmm. We don't just send it to people who checked a box that says, I'm interested in male breast cancer. Because the truth of the matter is that when you signed up to join the Army, you may not have known that 2 years later, your next door neighbor was going to get diagnosed with male breast cancer. And today you might get that email saying that there's a male breast cancer study, and you might print that off and hand it to your next door neighbor. And that might be a huge opportunity that ends up changing his life, you know?
Yeah.
And so we've got, you know, you would get that email, you know, whenever there's new research opportunities. And we try to cover the full spectrum of breast cancer research. So sometimes there's high risk genetics research. Sometimes there's trials looking at things like how breastfeeding or maternal fetal health affects our breast cancer risk. Sometimes there's population health questions that really diversifying the Army and making sure that we have not only women of color, persons of color, but also people with different LGBTQ backgrounds. Yes. Represented in the Army really helps us better understand our breast health.
Yeah. My final two questions. This pandemic, how has this pandemic, if any, affected cancer patients? And Dr. Graff, what would your final words be to our audience today?
Oh, the pandemic. So, you know, unfortunately, there's been a huge drop in breast cancer screening because of the pandemic. We saw a huge shift in the number of persons doing breast imaging, particularly early, like March, April, May. Mm-hmm. And I don't know that we'll ever recover those numbers because so often people program in, you know, your reminder is based on when you did it last year. And if you miss a year, you don't get the reminder. Mm-hmm. And so what I would say is, if you're listening, if you hear me and you didn't do your mammogram, oh my gosh, just go do it. Do it every year. If you missed and you're late, go do it now. Because we saw just a huge drop in the number of breast cancers diagnosed, which doesn't mean that there was a huge drop in breast cancer. It right. means that people are walking around with a breast cancer they don't know they have. Mm-hmm. And that terrifies me. Mm-hmm. The second part of the pandemic is that we also saw federal agencies and industry, so pharmaceutical companies, show us that they have the capacity to dramatically ramp up research. They did it big. They flooded the budget. They loosened the reins. They let us do telehealth visits for clinical trial participants. They let us give experimental agents, i.e. the COVID vaccine, to people on a different experimental trial. They were able to get the COVID vaccines through phase 3 research in an astronomical rate in a safe, effective way.
Okay.
And just to see us do something big, collaboratively, effectively, tells me that we can do better in cancer, and I hope it's a motivator. For everyone listening today, I would say that you should find doctors that you're comfortable with and can talk to. You should be comfortable pestering people if you don't feel like you're being heard. You should always bring up your questions and complaints. You should keep a list of things you want to tell your doctor in your phone, on a Post-it, in a notepad, in your purse, in your wallet, and bring it to those appointments to make sure that you're remembering, because it's hard to get in the appointment room and remember everything you want to do. I do that with my doctors. Participate in clinical trials as much and as often as they're available to you, because it is nearly always excellent care that helps move everybody forward, yourself included. And you're amazing, and I'm proud of you. Thank you for listening and learning about your health.
Thank you so, I will applaud. Thank you so much for educating us, and hopefully lessening our fear, or the fear of the word cancer, through this knowledge of prevention and advancement of breast cancer, and for educating us on what an oncologist is and does and what one can expect. Thank you so very much. I know your time is precious. I know we thank you. Thank you so much.
No problem. Thank you so much for having me.
Most definitely. Thank you.
Okay.
Bye-bye.
Bye. I am now gonna jump to my 3 o'clock call.
Okay.
Bye.
Bye-bye. How awesome was that? Thank you all so much for attending. I hope that you got that information. It was very quick, but yet it was very insightful information on oncology and the procedures of an oncologist, from our very own Dr. Stephanie Graff, Director of both Clinical Research and Breast Cancer Program at Sara Cancer Institute at HCA Midwest Research Centers. I, Phyllis Garnett, thank you so much for attending and for viewing. Be sure to share this video and to subscribe to our Garnett Cancer Society nonprofit for upcoming seminars and roundtable talks. Also follow us and like us on Facebook, Garnett Cancer Society. Look, you don't want to miss any events that we have coming up that are posted on our Facebook site, like the one we're going to have next Wednesday, the 17th, Coins of Love. So go ahead, go out to Facebook, follow us, like us, and until next time, know that your pathology matters.